if someone just wants to just quote microdose, as we just talked about, right? Um, how does a prescription get written for that? Because I'm seeing like a lot of pushback in the from between the prescriber and and the pharmacist in charge at these different pharmacies. How does that work?
You can't really write a prescription for off-label prescribing because a pharmacist isn't going to dispense it. They have their
Okay.
own responsibility to stick to FDA guidelines. But say you want to microdose them. Maybe you say to someone, I'm going to write you for the lowest dose pen, 0.25 milligrams weekly. I only want you to do 10 clicks.
Ah,
That will get you halfway to the lowest dose. I can't write the prescription like that because it's off-label use and there's no way to write it like that. But this isn't anything like sketchy. So think about
it's
prescribing
permissible. It's well within.
testosterone,
Yeah, it's within. Yeah. Yeah,
right,
okay.
for
Yeah.
women. We
Yeah.
can't even say I wanted to prescribe testosterone for women, which I do.
Right.
There's no way to write it. I have to write it as if I'm writing it for a man. So I prescribe
Wait. Hold on. Pause for a second.
Yeah.
Wait. Back up. Okay, so if you want to write a prescription for testosterone for a woman, you have to write it as if it's a man. Like, back up. Tell me more. I got to hear more. Hi, and thanks for watching and listening. My name is Mike Alden. That's Dr. Tara Marie Stacekel, and this is the Better Body Lab podcast.
Hey everyone, we are so excited that you are joining us for another episode of the Better Body Lab podcast. And today we have an incredible guest for you, Dr. Rekha Kumar, who's the Senior Medical Advisor for a company called Found. Maybe you've heard of them. They're doing incredible work in health optimization and weight loss. And I think what's really exciting, and one of the reasons that we're so excited to have you on today, Dr. Kumar, is because we've been talking a lot about moving from an injectable formulation of GLP-1s to an oral formulation of GLP-1s. And one of the things that you said that I think is just so apt for us right now is that 2026 is likely one of the most important years as we think about the impact and the uptake of people who are taking GLP-1s for weight loss. So we're really moving from what's next to actually what's here right now. And so, where I'd love to start is this idea between injectable GLP-1s and oral GLP-1s. Why does this shift toward offering an oral GLP-1, why does that matter so much in the marketplace and also to the people taking this medication?
Yeah, so thanks for the introduction and for having me. I do think 2026 is probably the biggest year yet for GLPs with the introduction of oral Wegovy. And the fact that there's an oral really democratizes the access to a medication that has now been shown to have so many health benefits. And what the oral does is that it gives people who are GLP-1 curious because of those other health benefits that maybe don't have as much weight to lose, it gives them an opportunity to try it without the commitment of an injection, without something that feels so medical and serious. Even though we're comfortable with the injection, injections are associated with more serious conditions, diabetes, chemotherapy, like the things that we associate needles and injections with are serious medical conditions. I'd say there's a spectrum of interest amongst people who want to use GLP-1s. There are people that legitimately meet the FDA criteria of obesity or type 2 diabetes, but now we're seeing a whole world of prevention, health optimization, PCOS, perimenopause, all these other conditions that may benefit, but the idea of an injection that's so long lasting may feel like too much.
I love that. One question that I think a lot of people are asking themselves is, am I a fit to take GLP-1s? I think you lightly touched on this idea that we're thinking about GLP-1s not just as a medication or a drug specifically for weight loss or significant weight loss. So, for someone who's listening to this podcast right now, what kinds of things would they be looking at within themselves or within their body to say, you know what, I might want to consider either an injectable GLP-1 or an oral GLP-1?
I would think about whether a person has done what they are willing to do on the lifestyle side or capable of doing. And again, I would never expect anyone, my patients, to be perfect with nutrition and exercise because that's not realistic. But if you are doing the best you can 80% of the time in terms of making the right food choices, moving your body, paying attention to quality sleep, and managing your stress. And despite that, perhaps your doctor has said your blood sugar's going up, your cholesterol's going up, or a woman in her midlife saying, you know what, my pants are tight. I'm doing everything right. I haven't done anything differently. I mean, those may all be these subtle reasons that you are GLP-1 curious, but maybe your primary care doctor doesn't feel comfortable giving you the medicine because you don't meet weight criteria. People know that insurance isn't going to cover this. And so it would take a lot of hoops to jump through to access the injection, possibly. So now that there's an oral, it's hard to separate it from the price too. With the coupon, it's fairly inexpensive. And so there is this opportunity now to try something that may be helpful if you feel like you've maxed out on realistically what you can do on the lifestyle side.
Mm.
You know, we're big fans of access. Tara and I talk a lot about access, both kind of how we grew up, and and when we were young, we didn't necessarily have access to a lot of things. Um, when I heard you talk earlier before we started recording, when I think of access on a fundamental level of can I get it, right? Can is it available, right? So we had the shortage right before, and the way you were describing it, I think earlier, the access part of it, it's more to it than actual availability, right? Kind of, if you could expand on that a little bit about what you mean, on a global perspective from access.
Yeah. So I think the word access is thrown around a lot when we talk about health equity and being able to get medicine either because of where you live, the cost of the medicine, whether you have private insurance or cash pay or a government plan. But really, access incorporates, I think, three concepts. It's price, convenience, and speed. So, can you afford this? Can you actually get this within your hands amount of time, right? Who wants to wait like 4 weeks for a prior auth when someone is motivated to do something? And the other is there a convenient way to get this? Do you have to drive to a pharmacy 50 miles away? There were people during the shortages that were, driving to pharmacies out of state and even flying to countries to buy their GLPs. So I'd say like price, speed, and convenience all fall under the definition of access. And I know people that had, plenty of money to buy GLPs out of pocket during the shortage, but it was so inconvenient that they just gave up. They were like, I can't be on the phone with this telehealth company or this like wherever for 2 hours on hold. And some of those were wealthy people, and they were like, I'm just not doing this. So price, speed, and convenience are all parts of accessing care and medicine.
Mhm.
But I think what I was trying to get at is you were talking about the pill itself, right? And the implication of an injection. I don't know if we were recording on that part or not, but you're talking about the implication of an injection, like really what that means, to a lot of people. It usually has this feeling of, some sort of maybe terminal disease or long-term disease. So therefore we don't access it because maybe from a psychological standpoint. That's what I was trying to get to.
Sorry. Yeah.
No, don't be
No.
sorry. No, no. Like, listen, we were going to get there no matter what. That's okay.
I just want to
But I thought it was
say,
a very valid point.
I just want to say I love the price, speed, and convenience element And I have ADHD, and so Adderall is often in short supply. And I have been a girl who's driven to all kinds of, obscure pharmacies or sent Mike to pick
Oh,
up the
yes.
medication with my ID, to get, Adderall in like a 30-mile radius. So we completely get it. And Mike, I love where you're going with this too, kind of like as a next level to say, okay, there's the, access, affordability, price, speed, convenience element. But then there's the psychological element of how does it make me feel to be injecting something in my body, and what meaning do I start to make of that? So I'll turn that back to you, Dr. Rekha.
Yeah, there's like a very medicalized connotation of injecting yourself, as there should be. That's a serious thing. It's becoming more mainstream. It's becoming more mainstream with GLPs to peptides to so many people doing fertility treatments. But I will say that for the average person, the concept of an injection can mean you're crossing into the lines of something very medical, scientific, something that carries more risk. Way back in the day, over 10 to 15 years ago, when we were prescribing GLP 1s for weight before anybody knew about this, our patients were terrified. When we had like off-label Victoza or liraglutide, even when Saxenda was FDA approved in 2014, and we would want to put people on it, people would say, "Oh my gosh, am I starting insulin?" And that was like the first thought people had. And so in terms of the way we're using the word access right now is that the pill versus the injection allows for an access that might be more comfortable to people to try something. People swallow pills when they have a headache, they take supplements. So not to minimize the scientific rigor of the pill, but it makes people more comfortable than an injection.
Yeah, yeah, that's what I was getting at. I mean, I've always been, afraid of needles. I've passed out a few times giving blood, so maybe that's it. But I think that makes a lot of sense. A lot of people are, listen, I have family members that are more than medically obese, and they're like, I'm not injecting myself with that stuff. I'm just not going to do it. But as you said, culturally, we're so accustomed to, we got a headache, we're going to take a pill. We supplement, we're going to take a pill. So it's just kind of easier for them. I'd like to jump into now the pill itself that we're talking about. But before we go into that actual pill itself, my understanding generally, again, I'm not a doctor, you are, but you know, the gold standard for efficacy as it relates to a pharmaceutical drug is an injectable because of the way that the body absorbs it, right? And then, when you think of pills as well, and the GI tract has to go through that. By the time it actually gets into the bloodstream or gets to where it's supposed to go, it's diluted, it's not as efficacious, and then the impact on your liver and your kidneys. So I'd love to hear more about just maybe kind of the delivery system first, and then the pill itself.
Yeah. So this thought that like injections are always better than pills, I wouldn't say is necessarily true. It depends on what the chemical structure of the medicine is. So the reason that GLP-1s have been injectable is because they're peptides. And that's something that's important to recognize. So they are a sequence of amino acids that make up a peptide, which peptide is a simple name for something that builds up to be a protein. The reason this is important is our stomach is designed to break down proteins. We have enzymes. When peptides or proteins hit our stomach, these things are broken down so they can be digested and absorbed. And so if something's not a peptide, if it's a small molecule, if it's something else, there's no issue with making that oral, right? We don't inject Tylenol, we don't inject Advil. We take those by mouth because they are broken down to a absorbable size that is still effective. Whereas a peptide had to be injected because historically stomach acid would have destroyed the peptide and made it ineffective. So the way they made this pill effective is by creating something called SNAC technology, SNAC. Ooh. And you could look up what that stands for. It's a long name. I actually made an Instagram video about SNAC. It's super nerdy, and
We
I
love snacks. Wait, what? What are we talking about again? I'm sorry.
When I
anyway, so
thought we were supposed to take this pill so we didn't have snack. No, I'm just
so
kidding.
this snack is
Different snack.
literally the technology that has allowed Novo Nordisk to turn this peptide into something that is able to be resilient despite stomach acid. So the SNAC technology creates a buffer around the pill when it's in your stomach, meaning that it buffers the pH so it's not broken down just around the pill in a local environment. And then it almost acts as like a little elevator to push the pill through the stomach lining. So not only is it not broken down, it's pushed across the stomach lining into the bloodstream. Before, we had an injection because we needed to find a way to get the peptide into the bloodstream without breaking down through stomach acid. Now we're saying, hey, swallow the pill. It's coated by SNAC. SNAC will buffer the stomach pH and push it across the stomach lining.
You
And
know,
that's what's new.
okay, so earlier, this is definitely before we were recording. I come from the supplement space, and I've seen all sorts of different delivery systems. I've seen a lot of time release technology, different coding on whether it be a capsule or a pill or a tablet, and a lot of it has to deal with time release. And when I hear about this pill. One of the things that I heard, maybe you can help me here. One of the things I heard is that it almost like, for lack of a better term, it hooks into the GI tract. Could you explain that? Is that accurate?
Yeah, that's an interesting way to think about it. Basically, it pulls it towards the stomach lining. So you could call that a hook. I called it an elevator to like push it. Um, but basically, in addition to protecting the pH around it to prevent degradation, we also need to push it over the stomach lining so it gets absorbed. And so, yes, not only is there the buffer, but there's sort of a hook or a pull.
Okay. So because that's the part when I understand, delivery systems and time release, these coatings, to me that technology seems fairly, simple and nothing really super special. But I know there's a bunch of patents on different ways. But this pill, when I heard how this works, you're using the elevator analogy. I'm using the hook analogy. Basically, what it is, it's getting to the place where it needs to go before it breaks down, right? So, how does it do that?
So the way, how does it act as an elevator
Yeah,
or
how does it know? Like how does it how does the GI tract, how does the stomach lining know where to get this pill to the right place before it breaks down?
Like this is such a like a funny question. I know so
But
many
remember,
people.
we actually don't want it to break down. So,
But I know that's what I'm saying. That's what I'm saying. I'm
yeah.
saying, how does it get to the place how does it get to the place where it needs to go, right? So then it can ultimately deliver the semaglutide. Like, how does it know where to go, right?
So actually,
And I don't know why this is
there's
funny, Taryn.
only,
I can't wait to hear why this is funny.
yeah,
But
there's
anyway.
only one place to go, actually. So if something is intact in your stomach, it could keep being passed through, I guess. It could go into the small intestine, but it will interact with the stomach lining. And then the stomach lining is dense with capillaries. So that's a way to get this immediately into the bloodstream right from the stomach wall. So exactly like how and why, I can't say that I totally know the science there, but um, there's two steps here. There's preventing it from breaking down, and then fully intact, the semaglutide needs to go through the stomach lining into capillaries. Then that's where you want it, right? That then you've reached the stage, because when you inject it into subcutaneous tissue, the way it's absorbed is through small capillaries.
Okay.
So once it's hit the stomach lining, you're good.
That's why I've actually talked to a couple of doctors in this space, and they're the ones that gave me the hook analogy, and that's the part that like makes sense to me. If I can visualize it, you literally swallow a pill, goes down the esophagus, gets into the stomach, and then it stays where it needs to stay. Basically, that's how I understand it. Does that make sense?
Yes,
Okay.
it stays temporarily, but then it gets absorbed.
Right.
Yeah.
Okay.
And then you're basically at the stage as if you injected it.
Right. Okay. That makes
I
sense.
think it's probably the one key thing that we're honing in on here is our small capillaries that have access to the bloodstream, right? So even when we inject this, we're injecting it so superficially. These are tiny needles, right? They're just going under the skin. But these things are going into the bloodstream because they're going through these tiny, tiny capillaries that are offshoots of our bigger vessels.
Okay.
And the same with the stomach lining.
Taryn, what was can't wait to hear my humor here.
Well, I'm just thinking about how you and I joke around sometimes and we're like, how it be? How it work?
I was thinking the same thing. Yeah.
I appreciate
How it no,
how it know.
because I was thinking like nanobots, or like you hear like nanotechnology, what everyone loves to talk about, but for me to understand it, I think the way you explained it makes sense too, but it's just easier for me the way because that's just the way I heard about it, and that makes total sense because that's why I was saying like I have a lot 20 years of understanding of mostly supplements and delivery systems, and we're always trying to, why is this one better? Okay, we have let's say, vitamin D or whatever, and we want it to absorb better. Well, oh, ours is coated with this special stuff, and it gets in. You know what I mean? When I hear about this technology, to me, it doesn't sound that new, but the part where it stays where it needs to stay, that's the part that's important. Next question that I have for you as it relates to that. I've also heard that there's a protocol that people need to do on a daily basis, or is it weekly basis, on what they can and can't do to ensure the efficacy of this.
Yeah, there's some more stipulations around swallowing the pill than there are with the injection. So the injection's easy because it doesn't time of day doesn't matter. None of that really matters because you're putting it right into the capillaries basically, and so it goes right to the bloodstream. So in order for this system that we just described, the hook, the elevator, the buffering of the pill, in order for all of that to work, there are some rules around what you can and can't do. So typically, in order for the SNAC technology to work, you want to take this on an empty stomach with only a few sips of water and wait at least 30 minutes to eat, because you don't want to
push it.
You don't want to interfere with the pH regulation of what is supposed to happen. And for some people that works. For others who take a lot of other medicines, people that take thyroid hormone that has its like own stipulations, those people may prefer an injection actually.
Interesting. I think we're starting to hear more about what GLP-1s can do for all of us beyond weight loss. And I'm curious, what else can GLP-1s help people with? Maybe that's medically, physically, mentally, that even goes beyond weight loss.
So I've been talking about this diagram I saw that is really cool, and it's that of an iceberg. And you have an iceberg that's floating in water, and most of the iceberg is underwater, and then there's a piece you can see above. I saw this diagram about GLP-1s, and on top of the water on the iceberg, it says weight loss, blood sugar. So that is the outward things that you see. You see the diabetes management, you see the weight loss. Under the water, where most of the iceberg was, there were words such as cardioprotective, anti-cancer, preventing inflammation, brain health, all of the other benefits. So I almost feel like when a patient or a person wants to be on a GLP for weight, I'm like, that you're barely touching the surface. Like, we are doing this for so many other reasons, and those are all of the reasons that are under the water in that bottom part of the iceberg, which are all of the other health benefits: reducing the risk of heart attack, stroke, cardiovascular death, optimizing fertility, treating fatty liver, treating sleep apnea. Some of these are weight related, but others are acting on inflammation independently. And so there are many reasons that someone would want to take a GLP-1. There are many reasons now having a pill may make someone more comfortable if they don't need that outward manifestation. If somebody doesn't need to lose weight and they don't have diabetes, but what if they want brain health and heart health and liver health? And what if they want all those things? Maybe taking a pill makes sense. And again, we're talking about off-label indications. It would take forever to get an FDA indication on all of these things, but we are learning from the science that there are so many benefits beyond just weight loss and blood sugar control.
Could you just give us a we had someone else on and she said she does a great job of explaining things on an eighth they said the New York Times eighth grade level. She was, I think, a fourth grade teacher at one point. She said she could explain. I said, could you explain it to me in a second grade level? Could you explain for our viewers and listeners, what off-label prescribing is and why that's important as a doctor?
Sure. So let's start with on-label prescribing. When we prescribe something on label or as per FDA label, that means that we're prescribing a medication for the indication that it was tested and FDA approved. So not only does that mean that you are prescribing a GLP-1 only for diabetes management or for a BMI over 30 or 27 or greater with a weight-related medical complication, but you're also on-label prescribing means you're prescribing to the population that was intended to be prescribed. So in medicine, off-label means when you leave those categories at all, you're prescribing to a person that doesn't meet that criteria. So for example, before these medicines were FDA approved for children or adolescents, now some of them are FDA approved starting age 10, starting age 12. Prior to that, prescribing to somebody under 18 was off-label use. You're prescribing to a person that the FDA didn't say on their label, this is who it's for. Or for years, I prescribed GLP-1s for PCOS, polycystic ovarian syndrome. That is not an FDA indication. It's accepted science that it's effective, but it is considered off-label use because the label on the drug doesn't say this is indicated for polycystic ovarian syndrome because that's not what it was studied for.
And what are the implications for you as a doctor and the patient as well? Are there additional, I don't know, warnings that you need to let your patient know about? Because sometimes when I hear off-label, I feel, I kind of understand it. I feel like it almost has like a negative connotation, like, oh, that's for off-label, you know?
Yeah, I think that it could be a negative connotation when you think of like access, cost, and coverage. So when you're prescribing something off label, especially something expensive that's off label, it's not going to be covered. And that is a big conversation with GLPs. There's a lot of people that want to try these medicines that are appropriate for them, and the benefit outweighs the risk. But we still have to say, because it's off label, I can't pass this through your insurance. I can try, but it'll get denied, and we're going to have to go a cash pay option. So I would say that it is relevant and can be negative because it makes things more expensive when people want to use their insurance. And the other thing with off-label use is that I do think it requires a risk versus benefit conversation with a patient. Hey, this isn't what this was intended for, but I have a lot of experience doing this. In you, I think that the benefit outweighs the risk and we should try it. Or you may say, in you, I think the risk outweighs the benefit and I don't think we should do this. So those are the kinds of conversations that clinicians and patients should be having when something is off label. And God forbid someone gets hurt. Say there's a serious side effect, and then the patient learns that somewhere else that drug wasn't for PCOS. That drug wasn't for you because you don't meet criteria. Then the patient can come back and be like, well, you never told me that. So you want to really have all of this out there beforehand.
Mm-hmm. Mm-hmm. You know, switching gears for just a moment, as I sort of cruise by the Reddit threads on GLP-1s, a common thing that a lot of people are writing in about is the fact that they've gotten a GLP-1, they've gotten an injectable semaglutide, people pronounce that different ways,
Just sema.
sema, tirzepatide, maybe they have the injectable, maybe they have the pill. And so then they say, okay, I started taking my GLP-1 and nothing has happened. Some significant amount of time has gone by and I'm not losing any weight. How should people think about what to do next if that's the case for them?
So in each of these cases, it should be individualized. So there are people that may not see an effect on the initial doses. There are people that might see too much of an effect. Their appetite is too suppressed. They're nauseous. So this is where I would go back to the clinician, go back to the prescriber of the medicine, and either say, hey, this is too strong or this is too weak. I think administration technique should be reviewed. Are you injecting this properly? Are you swallowing the pill properly? Are you separating out other food? Are you drinking too much water? So you should go over the administration technique and then adjust the dose. Sometimes you may need to switch from sema to terzi, in the future to Retta. So I think that there's going to be different people of different profiles that we're able to hone in on in the future, that which GLP is better for one person versus the other, what dosing schedule. But we always want to start gentle. We'd rather have somebody say, hey, I haven't noticed anything, but I'm okay. I'm not having a side effect, versus someone saying, I've been vomiting for 3 days straight.
Yeah, that's so tough. One of the things I love about Found and the work that you're doing there is really how much of a stance you've taken on personalizing the approach to metabolic health, obesity, and even kind of a broader suite of health optimization and longevity. One of the things that you've talked about, sort of in line with that personalization, is this idea of microdosing. And I think microdosing is still really new for a lot of people. Could you tell us more about what microdosing is and what that might look like relative to GLP-1s?
So microdosing has become a very trendy word, and we've been microdosing GLP-1s for probably 15 years. All that means is using lower doses, not necessarily titrating or increasing up to higher doses. Sometimes it means taking them on a different schedule than weekly. So whereas the prescribing indication or prescribing pattern is typically weekly, there are people that may take it every other week. I have menopausal women that are taking one dose a month just to keep their metabolisms in check. So the thing is, this has to be very individualized. So microdosing could mean many things. It could mean staying on a very low dose. It could mean using less than the lowest FDA prescribed dose. It could mean spacing it out more than weekly. And what's going to be really fun is microdosing with the pill. Like, what about people that want to do one every other day? Like, these are all the kinds of things that we can personalize and individualize. And this is what we've always done at Found. Found existed before the FDA approval of Wegovy. We were personalizing metabolic care to the old school generics that have been prescribed in obesity medicine for decades. And many people didn't even know that we prescribed meds before GLP-1s, but we actually did. And we use something called metabolic print at Found, where we create a personal fingerprint based on a bunch of intake data on what somebody's eating patterns, genetics, and on how we think they'll respond to meds. Their metabolic print or fingerprint acts as a blueprint for our doctors to choose a mix of medicines. It's a little different now because GLP-1s have become the go-to medicine, but even with GLPs, there's a way to personalize treatment.
I have a question about it, as it relates just the mechanics of it. So let's say semaglutide. And by the way, the dosing I'm about to say is probably not accurate, but let's say the average dose is 15 milligrams or something that's the starter dose, right? And let's say that's the starting, and if they titrate up, they double, what have you. Um, if someone just wants to just quote microdose, as we just talked about, right? Um, how does a prescription get written for that? Because I'm seeing like a lot of pushback in the from between the prescriber and the pharmacist in charge at these different pharmacies. How does that work?
So I'll make an interesting analogy. You can't really write a prescription for off-label prescribing because a pharmacist isn't going to dispense it. They have their
Okay.
own responsibility to stick to FDA guidelines. So, for example, take the Ozempic or semaglutide starting dose pen. The doses that are marked that it delivers are 0.25 milligrams and zero point 0.5 milligrams.
Okay.
In order to get to 0.25, the first marked dose, it takes 19 clicks or 20 clicks to get there. But say you want to microdose them. Maybe you say to someone, I'm going to write you for the lowest dose pen, 0.25 milligrams weekly. I only want you to do 10 clicks.
Ah,
That will get you halfway to the lowest dose. I can't write the prescription like that because it's off label use and there's no way to write it like that. But this isn't anything like sketchy. So think about
it's
prescribing
permissible. It's well within.
testosterone,
Yeah, it's within. Yeah. Yeah,
right?
okay.
For
Yeah.
women. We
Yeah.
can't even say I wanted to prescribe testosterone for women, which I do.
Right.
There's no way to write it. I have to write it as if I'm writing it for a man.
Okay. Hold on a second here. So you what? Back up. So you just said if you need to write a prescription for testosterone for a woman, you have to write it as if she's a man, which is so confusing. And for those who are listening and watching right now, the world of testosterone has really opened up for women. The black box warning has changed, which is great for women because turns out, and I think everybody knew this, that certain levels of testosterone are certainly beneficial for women, but. Tell me what you mean by that, and how do you navigate writing a prescription for a woman in a way that should be written for a man? That's so confusing to me.
Yeah, well, there is no FDA approved testosterone formulation for a woman. So we've been prescribing androgel, which is comes in a pump to men when they have testosterone deficiency or want to take testosterone. The prescription for a man is the number of pumps they should take of the gel. For a woman, the prescription, there's no different formulation, I prescribe androgel, which is the formulation for men that come the smallest denomination that you could squirt out as a pump. But I'm trying to get a woman to take a pea-sized amount, but I can't write that on the prescription. I can't say take a pea-sized amount. So I have to write it as take 1 or 2 pumps a day, but I say to the patient, the prescription is going to say 1 to 2 pumps a day, but you are going to take the size of the top of your pinky. And because if I try to write it as, a fraction of that, it doesn't get dispensed. The pharmacist will say, this isn't a thing.
Yeah. Wow. That's crazy. Since we are talking a little bit about testosterone and the gel, there's a lot of different ways right now that people can take testosterone. There are even pills out there. We actually know a company that's selling the pills, and allegedly it's not that destructive on your liver. So you have patches that I've seen now that are really kind of gaining some traction. So the gel, though, right, for women is problematic, right? For a few things, right? Especially if they're handling their children, right? You don't want what about an injection of testosterone for women? And by the way, I also know it's just again for our viewers and listeners, this is. I mean, it's not new, right? But it's relatively new within the general public because now, right, a lot of people are saying, okay, now because the black box warning has been removed, right? Where now it's starting to become more and more popular, so to speak. But why not an injection for it instead of the gel?
Yeah, and I guess just to clarify, the black box warning on estrogen was removed, which is sort of open this whole
Right. Yeah.
world of HRT or hormone replacement therapy up. And people not only want to replace their estrogen, but we may occasionally give women testosterone for libido, for maintaining muscle health. So there's many reasons for it. Um, I think what your question was, what was the original question
Well, yeah.
about
So why?
testosterone?
It's because the gel, right?
Oh, yeah. So could women inject it?
Right. Right.
I mean, again, there's no formulation of testosterone that injectable that we can prescribe in a regular pharmacy for a woman. So all of this, if we wanted to do it, would have to go through a compounding pharmacy.
Right. Okay. Okay. All right. And since we're talking a little bit about just your, so you do prescribe it. When do you prescribe testosterone for women? Like when do you see it's good for them?
Yeah, so it's again, just like GLP-1s, very individualized. When we are treating someone for perimenopause or menopause with hormone replacement therapy, and I normally go for like the estrogen and progesterone first, but if despite that they're complaining of low libido, fatigue, we can add in small amounts of testosterone. It doesn't work for everyone. I think if people notice an improvement, we do it. But if they don't, I wouldn't necessarily always keep jacking up the dose because I've seen women that have gotten high doses of injections, pellets, and their levels are really high. They feel agitated. Some women I've seen complain of growing hair on their face when the dosing isn't right. So I think we just, again, have to go super individualized, personalized, and start slow.
Is there, I mean, obviously there's, with men, you have to have a blood test to see where your levels are at, your different levels and different types of testosterone, GH levels as well. Um, for women, um, what is the biomarker? Like, what's low testosterone for? I don't know what the scale looks like for women. What's considered low, and why would they, want the testosterone?
Yeah, the problem with testing hormones in women is that like there's not necessarily like absolute numbers and the ranges are so wide. So what I would do in these cases is get a baseline, monitor it, and monitor symptoms. So see if you're actually creating a difference with the dose you're giving in the formulation you're giving it, and are they getting better? I think if the numbers are slightly going up from their baseline and they're reporting an improvement, then that's great. If the numbers aren't budging and they're not really saying they notice a difference, maybe go higher. Say the numbers are going through the roof and they don't feel good, then you stop it.
Mhm.
It's not for them. So I do think you have to monitor the numbers, but I don't think that there's like an absolute right or wrong for each person because so much of this is the way hormones oppose each other, right? So why do women occasionally say that they develop like a one annoying chin hair through perimenopause? Is it that they're like absolute testosterone is always higher? Not necessarily. It's the way estrogen and testosterone oppose each other. And as estrogen declines through perimenopause and menopause, the testosterone's more active. It's not that the level is necessarily so high. Someone could have a certain level of testosterone, complain of low libido, but still complain of like you know hormonal pattern baldness and the annoying chin hair. So it's really like balancing the hormones. It isn't exactly like an absolute level you're aiming at, unless you might be more experienced in this than I am, but that's the way I do it in practice.
No, yeah, it's Taryn. Actually, remember we talked to someone else about this, and I don't know that I necessarily knew this. I mean, look, men and women are different, but men, from my understanding, I did TRT years ago. My levels were super low. I went on for 6 months, and then that was it. And I felt great. I didn't, I just kind of got my levels up. But from my understanding is, it's like men, okay, here's the blood test. Here's your scale, 200 to 800. If you're at 200, it's pretty low. I'm gonna put you on, get you up to 6, 7, 800. Keep you there, and then you're good to go. But Taryn, someone was talking.
This is just one of the areas where men are so much simpler than
Yeah.
women.
That's it. Yeah. Yeah.
Yeah, I would say that it is much easier in men to replete testosterone because we have more guidance on what the levels should be. But I'd say it's much more complicated in women because we have a menstrual cycle. People's baselines are different. I mean, I guess even if somebody had their ovaries removed and you were controlling for that, you still have adrenal glands. Like it's really hard to know what someone's baseline should be.
Mhm. I
All right,
wanted
one more question about this. And Taryn,
okay.
I'm sorry. I always say I'm sorry about monopolizing it, but like, am I?
But
I don't
you're
know.
but you're not. You're not.
Yeah,
Yeah. If
I'm
you
not
were
really
really
sorry.
sorry, you would change your behavior. But
Yeah, yeah,
the
you know,
absence of behavior change demonstrates that you're not that sorry.
Taryn is a neuropsychologist and also a former licensed family therapist as well. So she knows. Now I just completely forgot my question. Okay. Oh, so no. So the question is, Taryn, you and I talk about this. You take control of your health. You are looking at things. You are having tests done. You're using devices to measure things. You're really actively taking agency over your own health. But a lot of women, as Taryn, you and I've talked about, they just feel like, okay, it's just happening to me. Therefore, I'm just not going to do anything about it. Doctor, like when should women start to maybe pay a little bit more attention and what sort of testing should they have done? You know, because you always hear in men, it starts to decline at 30. That's when we start looking at things. But when should really women take, notice of this stuff and what should they do?
I love this. I love this question, maybe minus the should, because I think so many women get so many shoulds about what we should be doing with our life. So I'd love to focus on like the could, like what are
Maybe
the,
you should have asked the question.
yeah, no, it's okay. It's a great question. I love this question.
I love this question too, and this is why I do what I do. And I don't know if I explained this correctly, but I actually do primary care and general endocrinology. So I like combining the primary care health with hormone health, meaning that I don't think there's any life stage that we couldn't be paying attention to this. Am I going to say that everybody should? I can't tell anyone what to do, but I think women need to be tuned into how their bodies feel from the start of adulthood. For it's not their job when they're kids to do that. So I'm just going to say the start of adulthood, and this idea that everything is stable, from your teenage years until you're 45 is not true. There are changes that are happening, through your 30s. Even if you think we don't reach our peak bone mineral density or muscle mass potentially until our late 20s or age 30. There's a reason we compare menopausal women's bone density to that of a 30-year-old woman. When we look at DEXA scans of menopausal women, that T score we're looking at is comparing to a healthy 30-year-old female, because after that, bone density declines if you don't do anything. So, although 30 seems very young, and in today's world, it is very young. Most people, shouldn't say most, but many aren't even thinking about having children. I think that people need to be aware that their bodies and their hormones are changing even in their 30s, in their early 40s. And perimenopause isn't the first and only change. There are changes in hormone levels, neurotransmitters, neurohormones. And the best example I have from practice is when, a 32-year-old says, I don't feel good. And we start going through the lifestyle and we talk about alcohol and sleep and stress. And they're like, but I've always done this. Like, I get that you've always done this, but maybe now your body's telling you something. You may not be in perimenopause or menopause, but your body at 32 is different than 25, and you may need to make changes. Not everything needs to be medicated necessarily, but maybe you do need to change how you manage your stress, how you balance your sleep, the way you exercise, the way you eat. And this isn't, to punish anyone. It's to say, you know what, we have to be aware that our bodies are always changing. And I think that's what's unique for women, where it really isn't ever stable. Whereas for men, I think a slow decline may start in the 40s versus, people talk about an abrupt decline for women, but lead up to that abrupt decline, there are still changes.
I'm not going to say anything anymore because I'm going to change my behavior.
Did you say you're not going to say anything anymore?
I'm going to change my behavior to show you that I understand.
I love it. Um, you know, I think one of the fascinating things that I wanted to talk about with you, especially building on that last question, is you talked about how one of the things that was really striking for you as a physician and kind of ultimately led you to pursue this path of endocrinology and metabolic health is seeing women in particular be blamed for metabolic disease, for being overweight and obese. And in fact, the information or the guidance that they were given is just eat less and move more. How do we, this sort of as a two-part question, how do we blame women less? Because we're already blaming ourselves for so many things. So how do we blame ourselves less? And what is the right information to have that's not just move more, eat less?
So, in these examples, to understand how to remove the blame or the fault, is I would look at a scientific example. So, we're talking about middle-aged women, perimenopause, menopause, where people are blamed when they say, I'm gaining weight, I can't sleep, and they say you're stressed, you need to eat less, move more. Let's look at women that get treated for breast cancer. These are women who may get chemotherapy, they might get their ovaries removed, or they get put on tamoxifen or anastrozole, which are anti-estrogen medications. Their metabolic health changes so rapidly. And this is a woman who has been put through either a surgical or a medical menopause, and things change so fast. You can't blame the woman there because she didn't do anything. It was such, if anything, these women are extremely motivated to make changes to try to fight the effects of these anti-estrogen medicines or of getting their ovaries removed. And when you see that example, you know that it's not the woman's behavior, it's the effect of hormone change. So in these cases, I would cite like the most scientific example of abrupt surgical menopause or a medical menopause with anti-estrogen treatment that women get when they're treated for breast cancer. And if you look at that and you compare that to a regular perimenopause or menopause, there's I can't imagine anyone that would look at that science and say, well, it's the woman's fault.
Mhm. I love that. I think this is my last question for you. Let's talk a little bit about glucose in our diet. I have heard, this may just be conjecture, you tell me, that we're still like one of the few countries in the world that talks about dementia as opposed to calling it maybe something like type 3 diabetes, glucose in our brain. We still talk about glaucoma rather than talking about glucose in our eyes. I'd love to kind of bring this all together and have you tell us a little bit about, is this glucose that's in our diet so detrimental relative to our health for things like dementia, for our eyesight? And can a GLP-1 be helpful in maybe mitigating how much glucose we're getting into our system?
I love this question. And to be simple, I would say yes, excess glucose is toxic for all of our organs. It's toxic for our brain, it's toxic for our heart, for our liver, our muscles, our fat cells. So the question is, what is excess? Is it a straightforward amount? And that's where I'll say no. The more muscles you have, the more you can use up glucose. So if you're really active and you have a lot of active skeletal muscle, either genetically, from exercise, from weightlifting, then it's hard to have excess glucose unless you're eating a ton of sugar. So it's a balance between what you're taking in and how much your muscles are using. So if somebody's very muscular, they have more wiggle room. They can eat more carbs, they can eat more sugar because their muscles act as a sink. The average American is quite sedentary, their muscle mass is low, and even eating a normal amount of carbohydrates becomes toxic because of low muscle mass. So, where do GLP-1s fit in? Yes, they can modify all of this. They can help us with our carbohydrate metabolism. But even on a GLP-1, you can get into trouble if you have no muscle. So it's a balance between the carbs and sugar you're eating, the muscle mass you have, and the GLP-1 you're taking. And that equation needs to be perfect. Not perfect, it needs to be manageable.
Amazing. That's so fascinating. I mean, we are talking about medical disorders like impact on memory and sight, and there's so little conversation about the impact that glucose has on us physiologically.
Yeah. I joke and I tell my patients that I think the biggest hack is working your glute muscles. It's the biggest muscle in your body. When trained and active, the amount of sugar your glutes can use up is quite a lot. So, but everyone has like flat, untrained glutes. But if you actually had a strong butt, the amount of excess sugar you could use up is kind of a lot more than if you didn't.
Okay, wait.
Yeah.
So let's operationalize that for just a second. So let's say as a woman, I train my glute muscles and I optimize them. And you'll tell us what optimize means. How much more glucose can my optimized glutes use as compared to the if I hadn't optimized my glutes?
That's a great question, and we probably can't even quantify it because the number of calories that the glutes burn at rest, if they're trained, can be like double or triple what fat cells would burn at rest. So trained glutes not only allow you act as a sink for sugar, but you can have a higher metabolism at rest. So not only could you potentially consume more calories and more carbs because the glute muscles would be active and act as a sink, but you probably can, you know, eat a pinch more. I mean, do I recommend only training your glutes? No, but I'm saying that like if you're going to do nothing, like work on your ass.
There it is. I'm doing squats today.
Taryn, this explains why I actually process glucose so well because of all the twerking that I do.
All the twerking.
Yeah.
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 Yeah, this is a little known fact
Yeah.
about Mike, and I don't know that he's released this publicly
Oh
before.
boy, I'm not sure I'm prepared, but go ahead. You can tell the world.
Yeah,
Yeah.
but early in the days, Mike grew up in the projects outside of Boston, and one of the things that he did early on was to work at Chuck E. Cheese, and
Hmm.
this is like in the 1990s, and so they gave out awards, for the
This is so
staff
great. This is
at
so
Chuck E.
great.
Cheese, like a paper plate award style, but I think it is an actual certificate. Mike still has it because he's
We're
very
gonna
proud of
post it. We're
it.
gonna post it now.
Yeah. So Mike received the award for best buns at Chuck E. Cheese.
Yeah.
I
Yeah.
love it.
Yeah. At a corporate entity that still exists, that was the award. And I will also say I received two awards. It was best buns and best looking as well. And look where I am now, you know?
Little did you know you were also protecting against glaucoma and dementia and
Yeah.
processing glucose like a champ.
Yeah. Because I was twerking in that kitchen like nobody's business.
Well, you both look very healthy. It sounds like your brains are healthy. I can't see either of your buns, but I'd imagine they're healthy.
Oh, well, thank you. Thank you for the vote of bun confidence. I
Great
appreciate
ass.
that. It's like an Al Pacino quote from what, Scent of a Woman? Is that what he said?
Yes, scent of a woman. Yeah,
Yeah.
yeah, yeah, yeah.
All right. Well, bringing us home, we are so delighted, Dr. Rekha Kumar, to have you here as the Senior Medical Advisor of Found. And of course, for those of you that aren't yet familiar with Found, it is an incredible opportunity for you to check Found out. Found has really grown, focusing on expanding choice, growing into one of the broadest metabolic medication formularies available today. I think there's something like more than 15 options if you're interested in checking out GLP-1s and how you can expand and enhance your metabolism, your metabolic health. And what we heard from you today is that the advent of the Wegovy pill is one of the most anticipated additions and really a strong signal in where weight care is going beyond injectable GLP-1s for 2026. So it has been such a delight, Dr. Kumar, to have you with us. Is there anything else that you want to share with us before we sign off, or any other place where you'd like our listeners to come find you and check out your work?
Yeah, people can definitely find me on Instagram or LinkedIn. I'm Dr. Rekha Kumar, easy to find. And I really appreciate having this conversation. It was really fun and informative for me too.
Amazing. Thank you so much.
Thank you.
All right, Mike, another great episode with Dr. Rekha Kumar, who's the Senior Medical Advisor at Found, and also a triple board certified endocrinologist in obesity medicine. She was so much fun and so knowledgeable.
It's great. Yeah. I just really love the guests that you continue to find. Just top of their game. Their education obviously speaks for itself, but they're also down to earth and and personable and really also excited about what they're doing and how they're helping people. Like I've had some, I think all of us have had, maybe some bad experiences with some doctors that just lack bedside manners, for lack of a better term. But these these guests that you're finding are just so great to help educate not only me but also our viewers and listeners.
Yeah, thank you for that. And it's been a lot of fun to think about what guests would really just be sort of a lighthouse of information. Because I think, you and I started this podcast because we wanted to be able to have these conversations and understand more about the array. This gets to one of your questions that you were asking about women. What are the array of options for women and men that we have to optimize our health, to enhance our longevity, for weight loss, for well-being. And, I think you and I wanted to have the conversations to be able to learn more about GLP-1s, about stem cells, about evidence-based practice, about cold plunge, about sauna. And so this is a lot of fun because we get to learn right alongside all of you, our audience, and also get to ask a lot of the questions that we're seeing either come from you or come through on places like Reddit, or from our clients, and be just another resource for all of us to learn, to really kind of democratize or share the information with everyone so that we all have an opportunity to enhance our health, because I think that's one of the greatest elements of wealth.
We end it there.
All right, everyone. Well, until next time, I am Dr. Taryn Marie Staskell. This is Mike Alden, and this has been the Better Body Lab podcast. See you next time.